Good evening, everybody. Today I would like to talk about our solution and experience with PFP, proximal femoral locking plate. I'm Dr. Watcharapong Yamsri. I'm general orthopedist. I work with trauma, spine, and arthroplasty. I work at Maharaj Nakhon Si Thammarat Hospital, Thailand. I'm graduate orthopedic surgeon from Chiang Mai University. Actually, in Nakhon Si Thammarat, we have 25 orthopedic doctors to take care 1.5 million people in my area. That means it have many cases, many accidents, and many trauma, many spine. That means that I must do everything, every case. Okay. And today, I would like to talk with proximal femoral locking plate, PFP. Everyone know proximal femoral locking plate has many design and from many companies. Today, I would like to talk about design from double medical company. Today, I'm very grateful and opportunity to share my experience to every. And I would like to say thank you for Double Medical for inviting me to share experience today. Everyone know about PFP, and I talk about the specification of the PFP of the double medical design. It have 3 points importance. One, I think, is anatomical contouring with the lateral side of the greater trochanter. And the second one is the 6 points of fixations is the provides the better rotational stability. And the last one is the multi-planar fixation, with protects femoral collapse. Oh, I would like to talk about indication. I think as everybody know indication, and the first one is the fracture of the trochanteric regions, including simple intertrochanterics, reverse intertrochanterics, transverse trochanterics, complex multifragmentary, and fracture with medial cortex instability. The second one is the proximal femur fracture with ipsilateral shaft fracture. And the last, the third one is the important, I think, metastatic proximal femur fracture. Proximal femur osteotomy, fracture in osteopenia, bone, non-union and malunion. Basic, transurgical femoral neck fracture, subcapital femoral neck fracture, and the last one is the subtrochanteric femur fracture. Next one. Today, I will talk about 3 cases. And I point at the problems, solution, and conclusions. It's the simple case. I show in my experience in my hospital. The first case is the girl, 11 years old. She has bicycle accidents. After 2 weeks, she come to hospital because she's still pain on when she walks. Okay? Everyone can see this film. The simple femoral neck fracture. Okay. Oh, let's see problems. I think problem is the femoral neck fractures and the simple femoral neck fractures. And The second problem is the delay union because two weeks post accident, and careful about growth plate injury in young adolescents. And solution of this case, many doctors can use multi-cannulated screw, but this case I choose PFP. PFP is the first reduction of the fracture size, and PFP of was applied and fixation with the compressed chin screw. And I temporarily fixation with three wide and 2 for parallel lines and 1 for oblique line for increased instability in rotational instability. Okay, and the picture on the right hand is I compress this fracture gap with standard can screw first in the parallel line. Okay, you can see this fracture gap is closed in the second picture, and before you compress the screw, you remove the oblique wire. When I already fixations, I changed the standard can screw to cannulated locking screw and insert multi-partner fixations. I followed through the surgical techniques, more stability and more compressions. After 1 year, she came to my hospital and I removed plate and all screw. Conclusion: that's the simple fractureness. Many doctors use the cannulated screw, but in this case I choose a PFP solution with PFP. I found that it's more compressions, more stability, and no complication of the avascular necrosis complications. Okay. The second case is similar, but go 12 years old car accident is the pain on motions and the hip joints. Everyone can see these fins, the fracture line and the intertrochanteric regions and subtrochanteric regions, and extend a long spiral fracture pattern extend from subtrochanteric region to proximal femur shaft. This problem is the fracture line is the long proximal part of femur, and in the same case, the problem is the growth plate maybe injury in the young adolescents. And let's see solutions. Solution is applies when the good direction. I apply PFP and I put the 1 cortical screw for compressions between fracture and plate. And be careful with the screw and growth plate. I point at these three points. 1, femoral head, no growth plate injury, and multi-cannulated locking screw is the what inserts, and you can see gap. This fracture size have a gap and the fracture size, and a long fracture proximal fracture size is the contour and fixation with the PFP. I follow surgical techniques. Let's see. Solution with PFP is the good alignment and more compressions, more stability, and no avascular necrosis complication. You can see at the fracture side is healing process is complete, is success. Okay, and the last case, is the multiple fractures. 58 years old male. He has motorcycle accident. He multiple fracture, and today I forgot to the proximal fracture is the combination fracture of the left hip. The fracture line intertrochanteric regions and multifragmentary of the proximal shaft of femur. First, applies PFP, and PFP, this design is not from double company. And I do wiring circuit wire at the multifragmentary for reduction, for full reductions, and one leg screw for stability and the multifragmentary. Okay. At this the greater trochanter PFP can restorations. Greater trochanter I think is necessary for the future, maybe revisions. And at the subtrochanteric regions is maybe non-union. What happened? The solution is the 8 month. After 8 months, he come to my hospital, and the X-ray, I found that the broken of the PFP at the proximal parts of the shaft of femur. And what will you do? I will revision with the long PFNE. Long PFNE. PFP can be restoration point of insertion of the long PFNE. After solution, I found that comminuted proximal femur fractures solution with PFP first and long PFA later. PFA can restoration greater trochanter regions, and treatment of non-union with long PFA is success, good alignment and more stability, and bone union without vascular necrosis. All from our experience with the PFPs. The PFP is the universal place for proximal femoral fractures. Why I told that? PFP can do at the neck fractures, in the throat fractures, subtrochanteric fracture, and shaft fractures. It's the universal place, especially for double medical company. Before in today's, I would like to show you to my feeling and my atmosphere at in my operative room. Let's see. Good team and good job. Only one doctor can do operation by themselves. Team is very important. Make everyone to be proud. Everyone is important. Thank you. My name is Dr. Watcharapong from Thailand. Thank you.